Dear colleagues, thank you for showing an interest in the inaugural DC&R online journal club and supporting our endeavour to promote lifelong learning in the field of colon and rectal surgery. This is a recording of our first meeting hosted by the colorectal department of the Cleveland Clinic in Cleveland, Ohio. Unfortunately, we had some technical difficulties with the live recording and therefore this video is somewhat shortened. We will be working hard behind the scenes to improve our meetings from month to month, and we hope to enhance your experience. I would like to wholeheartedly thank this team for working hard behind the scenes to make this happen. Now, last Monday we were in Cleveland, Ohio. Cleveland is a wonderful city. I personally enjoyed the sports and theatre scene during my time at the clinic. And at the moment, I watch with complete amazement at the Browns' winning record. The colorectal department is an internationally known and exceptionally busy unit. We are grateful for the Director of Training, Dr. Michael Valente, who has agreed to be the first host for our meetings. For me, of course, this is a home away from home. As the audience may know, this beautiful building is also part of the clinic campus. Perhaps next year, when we return to Cleveland, Dr. Steele will pull some strings and get us to have a colorectal debate right here. So, next article is presented by Dr. Rebecca Gunter and Dr. James Church. Thank you very much for participating. Dr. Gunter is a colorectal fellow. She has done her residency in the University of Wisconsin. Dr. Church, meanwhile, has a very illustrious career. He is not only internationally known, but almost recognized in all of the Australian states. And I think it's not an exaggeration to say that he's authored more textbooks and peer-review publications than I've probably read papers in total. So please, Rebecca, you have the floor.
Thank you very much for having me and for putting together this first journal club for DCR. The paper that I'll be discussing is the ligation of the intersphincteric fistula tract for high transsphincteric fistula yields moderate results at best. Is the tide turning? Written by a group from the Netherlands. Next slide. So this paper discusses this procedure, the ligation of the intersphincteric fistula tract, or commonly known as the lift procedure, that was first described in 2007. There are reported success rates throughout the literature ranging from 60 to 76%, including 2 randomized control trials. And the author who first described the lift procedure, Dr. Malicorn, published a series looking at the success rates over 10 years, and he reported a healing rate of 87.7%. The authors of this paper have somewhat different results of what has been reported previously in the literature, and they reported their results here. The next slide. So this is a single institution series with 2 surgeons with data collected retrospectively. They recorded all of their lift procedures that were performed for transsphincteric fistulas between November 2011 and December of 2018. And they defined high transsphincteric fistulas as being those that run through the middle or upper third of the external sphincter. They included both primary and recurrent fistulas and limited it to only straight or slightly deviating fistula tracts. And they excluded patients with Crohn's and those who had ongoing sepsis or abscesses. Next slide. And they described their operative technique as performing the lift 2 to 3 months after initial ceton placement for sepsis control. And they did not give perioperative antibiotics either before or after the procedure. They dissected the intersphincteric space and then isolated the fistula tract with a clamp and suture ligated both sides and used saline to test for leakage or completeness of their ligation. They loosely reapproximated the wound with absorbable suture and discharged patients home on the same day, again with no antibiotics. Next slide. Their primary outcome measure was the healing rate, which they defined as the external opening being completely closed with no signs of ongoing sepsis or abscess. And unhealed if they had recurrent external opening, they had recurrence of their previous presenting signs, either drainage or inflammation, and if their fistula persisted after 12 weeks. Next slide. And their secondary outcomes were a conversion of the transsphincteric fistula to intersphincteric fistula. Then they modeled the risk of recurrence using survival curves. And then they also measured pre and postoperative continence status using the fecal incontinence severity index. Next slide. Their series included 46 patients, the mean age at 42.5 years. 59% of the patients were male. The vast majority were classified as high transsphincteric, and 13% of the patients were recurrent fistulas. Next slide. Overall, their primary healing rate was 37%, or 17 of 46 patients, which included 4 of patients who were lost to follow-up. Their median time to failure was 4.2 months. And there was a tendency to toward more failures in anterior fistulas. And 20% of patients reported newly impaired continence, though all of those patients had mild incontinence. Next slide. In looking at their failures, 44% of these were persistent transsphincteric fistulas, and 55% were converted to intersphincteric. And interestingly, the authors of this paper sort of thought of this as being a downstaging of their fistula, or simplifying the fistula such that it would be amenable now to a fistulotomy, which 2/3 of those patients went on to receive with a 100% healing rate. And then on the patients who had persistent transsphincteric fistulas, the majority of them were treated with a transanal advancement flap repair with a healing rate of 77% in those patients. Next slide. So limitations of this were that it's a relatively small sample spread over 10 years with a single institution and 2 surgeons with data collected retrospectively. And then they comment on their selection bias, where of the patients that fit these inclusion criteria received a lift, and the rest received their sort of default, which was a transanal advancement flap repair. So there could be some effect of that bias based on their selection criteria. Next slide. So their conclusions were that they observed a healing rate much lower than what was reported in previous series. And they sort of postulated a couple of different reasons for this. And one being that the learning curve over the course of these 8 years, whether there would be a difference based on where they were on their learning curve. Although when they separated this by the early and second half of the series, they did not see a difference in healing rate. So they didn't think that that was probably the reason. There was a high rate of transsphincteric fistulas in this series, and they noted that in previous reports, the rate of healing with high transsphincteric compared to low transsphincteric is much lower. So that could be a reason why. And then they don't use antibiotics in their protocol, and Dr. Church uses them routinely for his patients after advancement flaps. And so this could be a reason why their healing rate was low. And then this led them to think about reconsidering patient selection for lifts versus flap repair, thinking that perhaps a lift is more appropriate for a lower fistula than the higher fistulas that might be better treated with a flap repair. So next slide. So I'll turn this over then to Dr. Church to comment on, give his comments or thoughts on this paper and its results.
Thank you, Becca, very much. That was a nice presentation. So I wanted to just mention 3 things about this paper. So the first thing is presenting a negative study. It's pretty unusual. And usually we're dealing with publication bias, where people do a lot of work but present their best stuff because they want to look good. Here, the authors have presented arguably their worst stuff. And then you have to wonder why. And the title kind of gives it away. It seems like they've got something against the lift, which I really don't blame them. And they want to turn the tide. I guess they're referring to a tide of anorectal surgeons all starting to do more and more lifts, and they want to stop that for some reason. But really, when you think about it logically, there are only 2 reasons. One is the lift is a good operation and they didn't do it right. Or the lift is a bad operation and they got the result that they kind of expected. And I think the jury is out on whether the lift is a good or a bad operation. My vote would be a bad operation for the following reason. The critical thing for fixing an anorectal fistula is to deal with the internal opening. That's where the sepsis gets in. I'm a believer in the cryptoglandular theory of anorectal sepsis, and you have to deal with that. And that's why the flap is such an important and such a good operation. And I realize that there's about 100 ways to do a flap, but if the flap is done well, you can get a very high healing rate because you've sealed off that internal opening and you've cured the patient. Anything that doesn't seal off and fix the internal opening is always going to have a high failure rate. If you just put a ceton in and that's all you do, and you take it out 9 months later, about 20 or 30% will heal just from doing that, which is similar to the results of doing these fancy little interfering with the tract operations, or lasering the tract, or gluing the tract, or plugging the tract. If you don't fix that internal opening, you're going to have a success rate of around about 30 to 40% that you would get from just doing nothing other than putting a seat on it. So that's, in my opinion, that's why a lift is a bad operation. So then you have to ask, well, why do the inventors of the lift have such good results? And I'm not 100% sure, but the other aspect of treating a fistula and getting successful treatment is to deal with the tract. So you can do a great flap, but if you allow a tract abscess to form, it'll burst through the opening and then you'll have a failure. So you have to do both. You have to fix the internal opening and then you have to deal with the tract. So dealing with the tract with the laser seems reasonable. The tract is not epithelialized, it's full of granulations. And that's what you want the ceton to deal with, is to get rid of the granulations, replace them by fibrosis. But the laser will augment the fibrosis at least. If it's a very short tract, I can see that the lift might do something to stop the pus getting back up into the internal opening. But honestly, I'm not 100% sure how the lift actually does work. So that's the philosophy. Now, looking at the paper itself, it's a very small series. It's, well, I think 7 years, 46 patients. That's less than 7 patients a year spread over that length of time. So if they want to talk about learning curve, there's no way you're going to progress on the learning curve by doing that few patients, that lower density of cases. They're highly selected patients. They've only chosen the very straight tracks and they've put cetons in for 2 to 3 months. So if ever it was going to work, it would be in these patients, and it hasn't worked. So I think I'm just wondering how it actually got to be accepted to the journal, and maybe Scott, you can comment on that, but it's a very small series. It has bad results, and there must be very few of these in the literature, I suspect.
Yeah, so I think that part of the take-home message with fistulas that I hope that everybody gets tonight has that they're hard. And to go what Dr. Leitner said earlier is that you have to manage your patient's expectations. So a lot of the things that we do with many journal clubs, and again, there's a lot of friendly faces on here tonight. It's good to see everybody, and Vlad, great job with putting this all together. But part of journal club, remember, is dealing with the actual disease process so we can all learn from one another, as well as to take a look at the paper. So to focus in on the paper, there's a couple of different things. And so I would say that in general, just to go back, because I want to make sure it's a very important point that Dr. Church says, is that in many cases, you have these papers that everything shows that they're great. Let's just take a walk back about fistula plugs. Remember the original fistula plug by Dr. Armstrong's group, and anybody out there can remember, but I believe, I haven't read it in a while, it was about 89, 87% in terms of success rate. Eric Johnson, who was with us at the Cleveland Clinic, also did a follow-up study, and it was high. And what do you see as time goes on? It's gone extremely down, and with many studies talking about the fact that it is on the order of about 20%. You know, we had fistula buttons for a while. You had fiber and glue that was supposed to be the end all, the cure all things. And that, so for whatever reason, you get this rush of papers in the start of some particular procedure. And in this case, we're looking at 2 kind of novel procedures, if you will, the laser treatment, as well as the lift procedure, that have shown good results. And then there's not much in the literature that says, wait a second, it's not as good. So I would agree there's a lot of problems associated with the paper, and truth be told, it is one of those ones that, you know, you're like, oh, I wonder how this got published, and that's a fair statement. But what I would tell you is the fact that if you look at that, what you don't see is typically a negative result paper. We don't see that across many different journals, and you certainly don't see it across many different disease processes, especially when it goes into surgery. So you have to take a look. Listen, in Journal Club, remember, one of the things that I encourage, I know there's just kind of scanning through the list there's a lot of trainees or people earlier in their careers right now. And the one thing that you can do is you can bash any particular paper. And so one of the things that we wanted to kind of talk a little bit about, I know Vlad had written me about, is what do you know, for many of you who are just starting to get into your kind of role on academic, and Dr. Church was the co-editor of DCR for several years as well, prior to I was, so he's got a lot of efforts in there. And so we have many members of the editorial board that are also on tonight, is the fact that what you want to do is you want to highlight the good things and then the bad things about the paper when you're writing your reviews. And so hopefully you'll be able to see that tonight. Walk through, see, you know, this is what the authors did well. Here's some potential problems with the paper. And it's important sometimes, especially early on, is to kind of categorize them in your mind in terms of minor issues with the paper and then some major points with the paper. It's kind of like what, you know, what is something that is, you know, not overcomable, whether it's based on the type of study that they've done. For example, is it a retrospective review? You know, is there something where you can match the groups or something along there? And so when you're reading these papers, it's important to kind of list those out and not just sit there and just bash the paper all the way through. So Vlad, I'll turn it over to you to kind of just continue on with this slide.
Next slide, please. There's a question from Dr. Rosato. So he asks, does anyone in the panel brush and wash the tract before any treatment? Does it help deepithelialize the tract?
So I'll just say what I like to do is to curette it, which I guess it's a way of brushing it, to remove any residual granulations. Hopefully the aceton that I've had in for a minimum of 6 weeks has done the job at turning the tract fibrous, but occasionally you'll find like a cavity associated with the tract. And then to me, that means I'm not doing a flap today. I'm going to drain that cavity and then the patient's coming back. Or if the tract is truly inflamed and full of granulations, then it may not be a good time to do the flap, even though the patient's already cleaned their colon out. We'll just back off, put another aceton in, drain it better, and then bring them back. So getting that tract ready is very important, as you're hinting.
I also see Dr. Valenti is on. Mike, how do you like to do with this? I know that the old Fistula plugs actually came in a kit, and as a part of that kit, there was a brush that they had in that you could kind of scrub the tract in. What are your thoughts?
Thanks, Scott. Thanks, Dr. Church, as well. Thanks, Vlad. I like Dr. Church's option of using the curette. I like the small mastoid curette as well. For some of the larger tracts, you could get a Raytech or a little gauze and kind of scrub it through, shoe shine it through. But those are very large tracts, which is not that common to have. But I also like the curette. And there was a brush in that old Fistula plug set, which was actually kind of novel idea. So something similar to that. But curetting is easy and simple and part of the set that we have.
I see that our editor-in-chief, Susan, is on. And I know, again, to kind of talk a little bit, Susan, thanks again for allowing Vlad to organize this. And maybe just the thought to go to the point, if you want to circle back about publication bias. That's a great question. It's a great topic. If you want to kind of just a little bit address that. And why aren't there more negative studies that show up in the literature? Is it just because they're not as kind of, you know, they're not as overwhelming, or, you know, what's the deal there?
Well, just a quick comment on the brush. I think the brush was the best thing about the Fistula plug kit. But coming back to publication bias, I think it's a big problem that editors don't want to publish negative reports because they don't have high impact. Nobody wants to read a negative study. But it's very important because for those of you who have done systematic reviews, if you're doing any kind of funnel plot, I mean, it really is important. If you don't have any kind of negative publications, it shows you that there really is a publication bias. And it's, doing any kind of operative experience is almost like doing basic science. You always wonder if Dr. Rojan School has some kind of special trick or technique he's doing when he's doing the lift procedure, and that nobody else can do, or why can't other people replicate his incredibly outstanding results? And it's the same thing if you have a basic science project. Why can't other people replicate basic science work? And is there some technique that the expert is doing that other people can't replicate, or that some trick or technique that the expert isn't sharing with others? And, so it really is important to share negative results so that you can have a really representative experience of other people doing the same procedure.
I hope Vlad is back. I just want to point out that the major benefit of having all these Zoom meetings is to always check out everybody's background. Susan, you look like you're a page out of Southern Living magazine with that high quality output there. Dr. Church is in the dark. I got Sklau, who doesn't even want to show his face on this. Amy's, I know exactly where she's at. I got my kids sitting in the conference room with the pictures of the chairs. It's so wonderful to see what everybody chooses. Somebody told me earlier, hey, your bar is showing. And so I went with this thing. So it's lots of fun, and I'm glad all of us could come together. So Vlad, you're back. I thought we lost you there for a second. So take it over, brother.
So thank you. There are a few excellent comments. I think Hanu from Melbourne comments about the question about doing anterior lifts in anterior fistulas for women, which I think is a very interesting point, because the intersphincteric plane is very difficult to find, I think. Another question that I thought about was positioning. Now, preferentially doing flaps, I personally decide whether the patient is prone or in lithotomy, depending where the internal opening is. But I do wonder for people that do lifts, whether they place all patients in lithotomy or not. But in the interest of time, I'd like to move on, and maybe we can put some of these comments on the Twitter feed and see if people can comment later. So next slide, please. So embracing technology, which packed up on me personally, we're going to try a poll. So if everyone can just click on what is their preferred view on where they sit on new technology and new techniques for the treatment of anal fistulas. And whilst we're doing that, can I go to the next slide? So I'd like to put a couple of questions to the panel in general. So the first question being, what do you think is the definition of success in the management of anal fistula surgery?
I can start with that. I think that a lot of that has to do with what the patient's expectations are and how symptomatic they were to begin with. So some patients, I think from the very beginning, are not very symptomatic. So some patients, the fistula doesn't bother them that much. So the expectations may be very different than a patient that has a fistula that's very symptomatic, that's causing them some level of incontinence. So I think that, ideally we get all fistulas to the point where they're not draining and they're epithelialized and the patient is entirely asymptomatic. But I think that that depends on the patient going in, how symptomatic they are to begin with, and also what the underlying disease process is. If they're a cryptoglandular fistula versus a Crohn's fistula, it's very different where you're going to get them to.
Thank you. Another question I have, pretty much every fistula study I've read, most of them are retrospective, comments about how universally important it is to do an RCT. From, say, to Dr. Steele, which questions in anal fistula surgery do you think at this stage warrant an RCT?
Yeah, that's a great point. And I think that one of the problems with a RCT is to have enough patience to try to get out so much of the variability that goes into the types of fistulas. We all know that, there's certain fistulas that the major thing you need to do is you need to just lay them open. They're low lying, not crossing much muscle, and you can just bring those, lay open the tract and go from there. And so, in my mind, when you're talking about, flaps, look at the variability in the flap literature. So if you're going to set up a randomized controlled trial about flaps versus lift or something like that, just even look at the variability that is within just doing one in and of itself alone. So you could set up flap versus lift. You could set up, what do you do with a high transferring? But I always worry, one of the first things I ask the fellows when they're with me is, do you really know what is an intrasphincteric? Do you really know what is a low-lying transsphincteric? And I think some of the times the fistula definitions in themselves, I worry a little bit about. Other things that you can take a look at is, there's been some studies that look at the diagnostic workup and the 8 of those in there, ultrasound versus MRI. There's some, small RCTs there, but I would just say that I don't know if I think there's a lot of bias and you need a lot of patience. So whoever is it, you probably need a lot of centers to really go after it so you can have all that bias work itself out, just because of the variability in that.
Yeah, Vlad, just to add to that, let's say we're doing randomized controlled study of flaps. You have to standardize flaps. Like I said, there's 100 ways of doing it. And so until you standardize it, then you can't investigate it. In the study that Becker and I looked at, the authors concluded at the end, there shouldn't be a randomized controlled study of flaps versus lifts because there wasn't equipoise. And I guess equipoise means that their outcomes are not similar enough to make it valid to do a prospective randomized controlled study.
Thank you. So our poll results are in, and interestingly, only 4% of the people think that their technique is best. If we had another option which said my technique is best and it's the flap, I would probably be able to separate Dr. Church from the other people that said their technique is best. But I think it is quite interesting that most of the people that deal with fistula surgery are not happy with what they're doing. That's how I take it. I personally am in the wait for long-term data group. I don't know if anyone has a comment on that.
I don't know what long-term data are going to give you in addition to what you have right now.
Yeah, but I just think the biggest fear for most people, especially earlier in their career, which a lot of the people on this Zoom call are, is the fact that you don't want to replace one bad thing with another. And the fear is, if you even talk about some of the mentors and some of the people who are going, Dave Schetz used to say, blow it open, Rick Billingham, just open that thing up, lay open the track. And other people are like, oh, wait, don't, put in setons and go from there. But probably one of the worst things you can do is take somebody who has, to go to Amy's point earlier, minimal symptoms associated with some mild drainage that they wear a pad for, and all of a sudden you replace it with full-blown incontinence, whether or not you have a wound that is healed or eventually healed, but now they can't keep control. And so, to err on the side of caution and to do that, it has led a lot of people to first go with the seton.
Okay, thank you. Let's move on to the next slide, please. So the next component of this journal club, we're going to try to have a invited guest speaker. And our inaugural special guest is Dr. Steele. And I suspect he probably clicked on the I want to be the first to have a go. But his CV obviously speaks for itself. I think from a personal anecdote point of view, so Dr. Steele hosts a party for the colorectal department every year. And it so happened that one year it fell on my son's birthday, and naturally my son, who at that point turned 4, decided that it was appropriate for him to be dressed as Batman to the director of colorectal surgery's house. And I think that this was so embraced by Dr. Steele that Frederick, my son, to this day thinks that that was his best birthday party ever. And so I think behind the unparalleled energy and focus and determination, which is at times heard in the adjoining OR, there's actually a very approachable family man. So with this, I'd like to start to ask a few questions about sort of preparing manuscripts and preparing papers. And my first question is, at what point in a research project do you decide on the target journal?
Yeah, it's a great question. And I know we're running out of time here, so I'll keep it very brief. I think you have to look realistic and say, you know, it's almost like choosing a residency or a fellowship or anything like that. You got your, you know, your college, you got your stretch journals, you got your, you know, ones that you can probably be able to get it into. And I think you need to be realistic with your data and realistic with your limitations of your particular paper. And, you know, a lot of people will say, do you write a paper with a target journal, or do they just kind of, you know, go for the whatever the, you know, nature medicine? What I would say about that is the fact that you got to be able to know your audience. And there's certain journals out there that are, you know, a little bit more one focused or the other. Are they more technique focused? Are they more basic science focused? Are they more clinical outcome results? I think that DC&R is, you know, a lot of historically clinical outcomes focused with it. It's not as much basic science, although we do have basic science. So if you've got a hardcore rat study, for example, on a fistula, it might not be the set journal. And you may want to be able to go a different route. I also think that you need to be able to say what's the type of study it is, and then, you know, and there comes a certain point where even within that, when you submit to a particular journal, I think one of the people, you know, sometimes people just harp on what is the negative aspect of what the reviewers come back. And I really think you need to take a look and say, you know, what are the good parts of that paper, and what can we expand upon, or how can we tweak that to focus on some of the good parts of it. But I don't ever particularly write a paper for a particular journal. Obviously in DCR, we want we want as high quality of papers as they can. We are the source for colorectal disease all around the world, and we pride ourselves on that. And we welcome all submissions in terms of that, but understand that there may be something that, you know, as you write, if it's, you know, small, we don't accept case reports, we don't do things like that, it won't fit the journal, and you're probably just kind of wasting your time and putting into that. Just like if I'm doing a randomized controlled trial of 48 patients, I'm not going to submit it to the New England Journal of Medicine. Although if anybody remembers that the pseudo-obstruction and neostigmine paper, I believe, had 11 patients and made the New England Journal. So I think people can look that up, and but that is a real thing.
Thank you. Now, the next question is, I personally hate rejections, all sorts of rejections. What do you think is the average amount of rejections for a good paper?
Well, I would say overall for a journal, and Susan's on, she can correct me if I'm wrong. Historically, our rejection rate for the journal is about 85%. Susan, is that a fair thing? I know it's been, the acceptance rate's about 12% in certain ones. So that's a rate around there. I think that's and she's nodding. So we're around there. So I would say you got to take a look and say, are you rejected outright? Did you get that major revision? And then, or is it something that you got a lot of positive comments? The one thing that I would say to all the people here, I don't know if there's an average number, but we do know that there's certain papers that, you know, you could see they've made the rounds. A lot of us are editors or on the editorial board for several different journals. I'm like, oh, I read this for this journal last week, and now you're reading it for another one coming up for there. I think that you need to look at the comments, and you need to understand a couple of things. Number one, if you get a major revision back, the first thing that, you know, we'll get a lot of comments on as editors, or you get an email back, and that will be like, it gives you the opportunity to resubmit. But what you see in many cases is that people kind of understand the limitations of what their data are, so they don't address a lot of the reviewers' comments, and they'll address some of them, and then it'll come back to us, and we'll send it out for review again, or we'll see it as editors, and it may get rejected again. So a major revision does not equal a publication. It gives you the opportunity to resubmit based on what the editor comments are, to try to be able to address that to make it a better publishable paper. And that cycle, depending on your paper, may go on and on, several different iterations, but understand that a major revision does not. It's very, very infrequent that you're going to go ahead, if you just base on all of the different journals, that you're going to not get a rejection upfront on the majority of your submissions.
Thank you. The next question I have is the authorship order. Now, I understand the first person does most of the legwork. The last author is the one who's overall supervising and has the conceptual understanding. How do you organize the middle?
Well, I think that first, just about in terms of authorship, I would encourage everybody, there's a lot of different things out there now that talk about ghost authors on that, or kind of authors that meets, just not really authorship criteria. So we have set criteria. You can find them on, as a matter of fact, as a part of the submission process, to say, what did you contribute to a particular paper, and you need to meet authorship requirements, and that's part of the submission process. The days where me as the chair, just because I'm the chair and I don't contribute to it, it just gets stuck on a paper, that's not correct, and we don't want that. And people shouldn't demand that. The biggest thing that when I run a research conference, that I think that people should do is people should have an understanding of where they fit in. Certain people do it by rating, certain people do it by alphabetical in the middle, whatever it is that you in your study group for that particular paper, it's best to do that up front, because there's nothing that kind of makes people more upset than when they either get left off, and that's happened to me before, in terms of me forgetting somebody on a particular paper as those papers go on through different revisions on them, or there's a concern about, I did this and why am I not second author, or why are you last author, and everything. And when that paper gets far enough down the road, that is a setup for a lot of hurt feelings and a lot of problems. So I think it's best that you get all the authors together and you say, this is what you're going to do, this is how you're going to contribute, and then this is how our author order is going to be right up front, and especially as it relates to first, second, and probably last author.
Thank you. Sorry for sort of grilling you. I think I've got about 3 more questions, if that's okay.
We can go rapid fire.
With the manuscript, in the mechanics of submitting it, what grabs you in a supporting letter?
I actually like the supporting letter, because I know a lot of people may not want to read them. I think it sets the tone for me in terms of what I'm going to go after. What does grab me sometimes is, this paper was published in 1997, and in some particular one, you're like, wait a minute, like, it's 2020. What happened to this data? Or, it's kind of just, if things aren't adding up, in many cases, that might be something that kind of grabs my attention. But I think it's an opportunity for them to say it hasn't been published elsewhere. This is where it has been presented, if it's been one of these ones, and it kind of gives you a little bit of an insight into the mind of the authors in terms of what they were trying to accomplish with a paper. Probably the worst thing that you can do in that is you can, not be completely wholesome about what that paper's been, and we've seen that in a couple of different ones where it's not been published elsewhere, and it actually has in part been, and that's been a problem. And we have software to be able to track some of these things. And, on one of the journal clubs, we'll go through some different type of things, such as salami slicing or dual publications. And Susan, if you can come off of mute, what would you say every year we get, how many dual publications, or kind of catch people in the middle of that? It is not infrequent.
There are several every year, and the Authenticate, which is the plagiarism software, is run on every manuscript, both on submission as well as on acceptance.
Thank you. Now, how does the editor or associate editor choose the reviewers?
That's a good question. So I think a lot of us try to, we try to pick experts in the field as much. Everybody has a little bit of a niche, and it's important to try to figure out, who knows a lot about that particular topic. Obviously, we don't want to have bias in that, so that somebody who thinks my way is the only way and there's nothing else and gets it. What I look for in many cases is, one of the things that happens behind the scenes is that each of the reviewers also get their reviews get scored and get graded. And you kind of get to know the reviewers, and you kind of get to know a little bit who's a hawk and who's a dove. And so you don't want to, put a paper to, 3 hawks and they just get thrown to the wolves, and that paper never got a chance. That's unfair to the authors. But we really do want to give every manuscript a fair view. We try to get a minimum of 3 And then sometimes the hard part is if you get one accept, one reject, and one major revision. And so sometimes you'll see additional authors on there, or somebody who has a particular, an expertise in that particular topic. We always want to make sure that we have that, because it's, you don't want somebody who doesn't have any idea on that. So I'll look oftentimes for people who have published in the past, or somebody who I know that maybe has done a recent CPG on it, so they're very familiar with the literature. We do try to give it a first pass and try to give the author the initial benefit of the doubt as co-editors, and as Susan as editors amongst ourselves. We actually look at our rejection rates up front to make sure that we're not disparate between the three of us. But the goal is to give you feedback. Now, that may not be the feedback that you want, but our goal is ultimately to make it a better paper. Because as I said before, the reality is that you can bash a lot of papers, but people put a lot of hard work into them, and we try to look for is there something there.
Thank you. My last question is, and you've kind of touched upon it, but what makes a good reviewer?
Yeah, so that's a great question. I'm glad you ended with that, Vlad, because we're 12 minutes over time. So, and thank you for saying thank you after every one of my answers. You're so polite, Vlad. I missed that. So what makes a good reviewer is, first of all, availability. What I would tell you is that we have over probably 500 reviewers or more. At last count, Susan would probably know the latest and greatest number, but there's a lot of people that are in editorial manager that haven't reviewed in a long time. We would be nothing on a journal if it wasn't for our reviewers. That's first and foremost. Our reviewers, it's a volunteer thing that they're able to do, that they want the best thing that's in the literature there. So first of all, thank you to many of you who have reviewed for us in any journal in the past, as well as if you're going to do it in the future. So availability is number one. The second thing is, we can tell a difference between somebody who has done a review. You can almost tell in the past, before COVID, when you almost seemed like somebody was doing it on the plane, and it's really, a couple of things. You're like asking questions that it's right in the manuscript and they didn't give it much effort. That's not really fair to the authors to kind of give that type of review. So the other thing that I would say in that, in addition to giving, I already talked a little bit about hitting some high points and then hitting some major and minor criteria, is the fact that if you look on any one of the journals, they typically have blinded comments to the editor and then blinded comments to the author. What's critically important as an editor, and I know Susan would feel the exact same way, and if John is on, is the fact that when that is your time on the blinded comments to the editor to tell us what you really feel. And you don't have to be rude or anything, but it's nice to know and say, listen, I've read this paper before and it is nothing, or there's 3 more of these like this, or you're trying to be polite, and we try to be polite, and we're not trying to be rude to the authors, and then you kind of tell us what you really feel, and it gives us a much more kind of robust or overall view of the paper itself. So use those blinded comments. Don't just cut and paste your blinded to the editor into the one blinded to the author. Just talk to us like you're calling up a phone and say, I had that, this is what I really feel about this particular paper. Susan, do you want to add anything else in there?
Well, I think many times for papers that are from underserved countries, I'll send them out for review just to give the authors valuable feedback on how they can improve the paper. And I think we want every paper that gets submitted to DCR that is reviewed to have valuable feedback for the authors on how they can improve their paper, whether or not it's published in DCR. So I think collegial comments for improvement for the paper are really important to the authors. And it's very important for reviewers to not include value judgments on the paper, whether it's positive or negative. If, for example, it's really difficult if the reviewer says, this is a wonderful study, or this is an excellent study, and another reviewer says reject, and the author and the paper is rejected, because I edit out all those value judgments. But so it's really important to keep an unbiased review to hand in for those comments to authors.
Okay, thank you again. Next slide, please. So I guess this brings us to the conclusion of our first journal club. we extend the gratitude to the colorectal department of the Cleveland Clinic for being our first hosts. I think it's, I personally am delighted. I thank all the guests for attending, and hopefully some viewers on the YouTube channel that may look at it later. And I'm very thankful that everyone is supporting us and promoting lifelong learning in the colorectal community. Our next journal club will be on the 2nd of November, and it'll be hosted by Penn State. So I hope to see you there. Thank you.
Thank you, Vlad. Fantastic job, and everybody have a great night. And just, we welcome all of your feedback. We want to, as a journal, we want to make sure that we are providing you and your residents and your faculty what you need to be able to use some of our papers. And as Vlad creates these journal clubs, and the more interactive we can make it, the better off it is for all. So everybody have a great evening.
And give us suggestions for improvement, please.
Home sweet Cleveland.
Yeah. Good job, Vlad.
Excellent job.
Good night.